Like something, right?
You're all set?
Good morning, everybody. Today is Thursday, March 12th. It is 10:02, and we are starting our Health and Human Service Committee meeting. We do have a few changes to the order, to the agenda, just to move things up to get a few department heads back out. They have quite a busy schedule. Do we have any public comment? No public comment. Can I get a mover of February 18th minutes? Veronica moves, Christie seconds. All those in favor? All right, we are moving quick. We got some appointments. Human Rights Commission, Elizabeth Brutidge, Commissioner, term expires December 31st, 2027. Amina Jallo, Commissioner, term expires December 31st, 2027. Do I have a mover? Rachel moves, Christie seconds. All those in favor? And then we have Youth Services, Lisa Monroe, Town of Enfield Representative, term expires December 31st, 2027. Do we have a mover? Veronica moves, Rachel seconds. All right, all those in favor? We're already at the chair's report. Oh, wait a second. We have 2026 Health and Human Service Committee liaisons. We have two. I know there were some emails that went back and forth. I couldn't remember who said what, so we'll just see if we can figure it out now. We had Human Service Coalition Board of Directors and Health Planning Council. Was anybody interested in which one? Human Service Coalition is Rachel. And then the Health Planning Council is the second Monday from 12 to 1:30. There's no meetings July, August, and December. Meetings are either hybrid or in person, depending on the agenda. In-person meetings are held at whole health offices at 55 Brown Road. Is anybody interested in that? No, no, no? All right. I will do that one. Can we vote now?
No, you don't have to vote for it.
Oh, okay, cool. Chair's report. We did the liaisons. We have a presentation from REACH, the Respectful, Equitable Access to Compassionate Healthcare. Come on up, Samantha.
Where should I go? Does it matter?
No, you can sit anywhere.
Okay.
You can sit right next to Mike in my old seat.
It's a friendly place.
Is this your old seat?
That's my old seat.
Oh, perfect. Okay. Do I have some slides. How do I?
So you would join the Zoom and then hit the blue button that says share screen.
Got it. Hang on just a second.
While we're waiting for Samantha to connect, I'll jump down to number 8 on the agenda, the Human Service Coalition Working Group. We are looking at scheduling a meeting in the next 2 weeks. Norma's working on scheduling. We had to work out the numbers of the group. You can only have 2 members of a committee on a working group. So Christy and I will do the HSC committee, and then we'll report out to you all in April at our April meeting after we have the first meeting. Hopefully during the first meeting we can get the first step done, which is the priorities for this year's grant cycle. That's the first step. So hopefully in April we'll be able to come back and say what the 5 to 6 priorities are and go from there. You ready, Sam?
I think I'm ready, yeah.
All right.
Okay. I am not going, I know there's some new faces, so I'll just introduce myself. My name is Samantha Stevenson. I'm the Director of Operations at REACH Medical. I'm not going to spend a lot of time just in general. I'm going to keep it short and sweet, but I thought maybe we could start for the folks here that may not be familiar with REACH, just about like giving a list of our integrated services so people have a better understanding of why we are taking on an initiative moving into housing. So as Travis said, REACH stands for Respectful, Equitable Access to Compassionate Healthcare. We opened our doors to the public in February 2018. Right now, we serve about 10,000 unique patients across 56 counties in New York State. Obviously, our top county served is here in Tompkins. We have about 2,000 individual patients that remain in care with us. You can see at the bottom there, we have over a 75% retention rate in care, and we measure that by people who remain in care for a minimum of 6 months. And this bullet here about the Medicaid eligible patients, over 75% of our patient population are Medicaid beneficiaries. And that will play an important role in explaining medical respite soon. So here's a list of our integrated services. The very top one is our addiction medicine department. And so when I say 10,000 patients, that number is based on this top one, the MOUD. And so all of our integrated services listed below on the next 2 pages are offered to patients that are established in care with us for MAT. So we do primary and acute care, Hep C and HIV testing and treatment. We have a large outreach team, which I'm sure most of you probably know in this room. We offer PrEP. We have fully integrated behavioral health and crisis management. So we offer real-time behavioral health counseling, de-escalation. We have providers on staff that do psychiatric medication management. We have psych RNs, psych NPs. We have, we're an OOP site, so we do a lot of Narcan training and Narcan distribution. Our outreach team takes out Narcan everywhere they go, so we disperse a lot of that. We keep the library vending machines stocked with Narcan, so there's a lot of that. We offer intensive case management and general case management for all of our established patients. We house the LEAD program, and that started in 2020. And that's been an incredible program, and it has pulled in a lot of community partners and helped a lot of people both get to a place where they are removed from swirling around in the criminal justice system and also stabilized out and ended up in permanent supportive housing. REACH just moved to a new location downtown, right off the Commons in the Hilton Garden building, and we were able to open up a full food pantry 5 days a week, and we also have a navigation drop-in center that's fully operational, and that runs 5 days a week, and that's something that we've been talking about and working towards for a long time in our community. So, and that drop-in center is busy, but it's really nice because we help people in the moment, on the spot, Monday through Friday. Additionally, REACH has an addiction medicine consult contract with CMC. This is another key piece of information that will come into play later when I talk about medical respite. We provide daily medical rounding at the hospital for anyone who is admitted for a substance use disorder related diagnoses. So we work directly with inpatient people, and we provide education to both residents and providers at the hospital around addiction medicine services. We are also launching a big grant with CMC this year, which most of you probably saw their press release. And that is REACH housing the work of that, and it's going to be street medicine, and what that will do is pair resident learners out in the community, on the streets, in the encampments, in the shelter spaces. It'll put doctors out with our outreach workers. So we're looking forward to that. And then this fall, we got another grant to expand our behavioral health services, and we will begin offering evening hours as well. So what we're proposing is moving into a blended model of supportive housing and medical respite. Medical respite, the nearest facility that we have now is in Albany. So Tompkins and all of our surrounding counties have no option for individuals who are admitted into the hospital and experiencing homelessness. So what medical respite does is it guarantees that people being released from the hospital will have a dignified place to recover. It should alleviate any exacerbation in our shelter system locally for helping people with medical complexities recover in the shelter system. I have been meeting with Brittany about this as well and talking through the need and kind of what that looks like and how the goal will be having a bi-directional referral system. And through our initiative at CMC, where we have providers rounding every day, we estimate that there's around 4 individuals at all times that in Tompkins that are admitted to CMC that are eligible and in need of medical respite. So through that program, we will be able to discharge people directly from the hospital into medical respite. Medical respite is a service that is certified by New York State. They require on-site staffing 24/7. So this is kind of a one-of-a-kind model, especially because we're pairing it with permanent supportive housing, which I know is a big topic right now, and rightfully so is going to come with a lot of questions. This model that we're proposing is very unique in the sense that in the former shelter building, 618 West State Street, we will have both medical respite units and permanent supportive housing units on site. REACH staff will be on site 24/7. So you'll have licensed, certified staff 24/7 around the clock providing all of the services that REACH provides. All of those integrated services will be available to everyone who is either living there in a permanent supportive unit or there temporarily for medical respite. These are just some cost-saving health outcomes. I'm happy to share these slides with anybody that's interested afterwards, but essentially it makes sense when you think about folks that are experiencing homelessness, getting discharged to the streets or getting discharged to the shelter system. What that does is it puts a strain on the shelter system. It puts individuals in locations that do not have licensed medical professionals. It demands accommodations that we may or may not be able to fulfill. Medical respite meets those needs, and it decreases the chance of people entering back into the hospital system by 40%. And so in the medical respite model, here you go, sorry, I have to move this. So you can see there's a 40% reduction in inpatient days, a 26% reduction in emergency department visits. So there's tremendous savings in Medicaid and managed Medicaid dollars at its baseline, in addition to improving the quality of life of individuals. So the operational model and sustainability is, like I mentioned, it's 24/7 licensed staffing. Our daily medical rounding will be able to facilitate bed-to-bed facilitation right from the hospital into respite, where everybody will have full access to all of our integrated services. We have intense case management and licensed providers that will be on site every day. Medical respite allows individuals to stay in place for 90 days to recover, and if they need additional, we will be able to write that with our providers on site to extend it out. So it could be extended if needed. New York State also requires every participant to have 3 prepared meals per day. So it's meeting food insecurities as well as medical needs and shelter needs. And I think one of the big pieces about medical respite is it's a reimbursable service, which means that REACH, through our licenses, through our provider licenses, through our OASIS license, and eventually our respite license, will be able to leverage managed Medicaid reimbursements for the majority of the care that we're providing, which allows us to provide a lot more services for not a lot of funding. So we will be able to meet people's needs case management wise, addiction medicine, wound care. We can treat people's Hep C while they're on site. We can get HIV under control. It will increase public health. It will decrease the strain in the system. And these are all services that are reimbursable through the REACH license. So this is a model that really sets us apart in that way. And additionally, so we've already been awarded an ESHI grant for the permanent supportive units on site that will also offset costs. So the goal is, and this could change because we're in the early stages of development, we do have a fully executed purchase contract for the 618 property, which is the former shelter. We just put out a bid to multiple architects to start the process of HHAP applications. We also have already been awarded a $600,000 transformation grant through New York State that will be allocated towards this. So we believe that what the numbers will be is 10 permanent supportive units and 10 medical respite units, but that could be subject to change slightly. Joe Bose is on Zoom. I don't know, Joe, if you want to cover Joe is our contracted developer that we're working with. I assume most everybody is familiar, and I don't know if, Joe, do you want to cover the budget?
Sure. Hi, everyone. I'm Joe Bose. I'm a real estate development consultant working with REACH. And yeah, as Samantha said, we're in the early stages of evaluating the building to determine the number of units that are going to be possible. But we think we can get 20 apartments. Each apartment would have its own bathroom. 10 of those would be medical respite and 10 would be permanent. And they would be integrated throughout the facility. But this is our initial budget based on, the experience that we have doing these types of developments. And, the nice thing about this building is that it's in really good shape. The interior needs to be redesigned to make sure that it's up to code and meets the medical respite and permanent supportive housing needs of REACH and residents. But, it's not like we need to build a new building. So this is our estimated sources and uses, and happy to take any questions, but we think this is a very fundable project that, we've already had several conversations with New York State about the HHAP funding, which is the majority of the funds here, and they're very supportive of an application. And we've also submitted an application to the city of Ithaca in their current home round.
Oh, the $1 million. The city of Ithaca money you applied for, is that part of that thing I just read about in the paper, the $1 million? Or is it some other funding source?
We applied for, I'm not sure what was in the paper, but we applied for $100,000 of home funds.
Okay, yeah, I think that's the same. All right, cool, thank you.
I have a question about when you would know if you got the HHAP funding.
So we expect there to be an application in June. It will be due in June. And then probably before the end of the year, there would be an award. So hopefully in the fall, the fourth quarter.
Thank you.
We're also working closely with CCN, who is the social care network for the 1115 waiver. And part of the requirements of them holding this hub of counties and being this SCN for them is that they have to get medical respite up and running. As far as we know, REACH is the only organization in all of the counties that's positioned to do this. So there's a lot of support from their end also to meet the need of our population. And the goal, of course, is to pull approximately 20 people at any given time out of the system in Tompkins that is serving the chronically unhoused population, and pull them into a highly supportive, highly I don't want to say regulated, but medical respite is much more regulated than any kind of supportive housing facility that we know of, right? Because it's a licensed New York State facility. We have to meet a lot of different regulations. We have to have that 24/7 staffing. And it will be, of course, housed by REACH, which means that it comes with a large spectrum of integrated services. So the goal at any given time is to permanently remove 20 people from the system here in Tompkins.
Samantha, would you like us to wait till you're done for questions or just jump right in?
Yeah, you can just go.
Rachel?
I was wondering if this would also be a regional medical respite, because you mentioned that the only other one is in Albany, and that is CCN Care Compass?
Yes.
So if they're supporting this also because they need it for their network, would
Yeah.
we?
It could be. We're trying really hard to find real data to assess the need so that it can inform our model on how many medical respite beds should be broken out in this, what we're estimating to be like a 20-unit building. It's hard because it doesn't exist anywhere. And so we're talking to hospital, like, you know, a hospital can anecdotally be like, we have 5 people. So assessing that need has been really tricky for us, but if we continue working with the 1115 waiver, which I think we intend to, it could be a regional, we could be getting referrals from other counties for people to stay just in the respite beds. But we want to make sure that there's enough respite units to meet the needs.
So would it prioritize Tompkins County residents?
Yes.
Okay.
Mike?
Actually, I have just kind of 2 questions. The 10,000 unique patients, are those all MOU?
Yes.
Okay.
Yes.
So is that your primary, I mean, are all patients that go to REACH MOUD? Or?
About 95% are, yes.
No, fair enough. So when we talk about medical respite, are we talking about, like, I'm addicted to opioids, but I had a heart attack and now I have to recover from that heart attack?
Yeah, so in
Or is it more?
In medical respite world, you don't need to have a substance use disorder to get the respite services. What qualifies you is that you are a Medicaid beneficiary that does not have a safe and stable place to recover from a medical condition.
Okay. But well, it sounds like MOUD is considered a medical condition.
Yes.
So how, I guess, what is this? Listen, I'm all for this, so I'm coming from that.
Ask away.
I just don't understand, like, the respite, who is it kind of for? Like, is it just for me to recover from a drug addiction, or is that really not the goal? You see what I'm saying?
I think I do. I think it is the purpose of medical respite is to give the unhoused population a safe place to recover when they need to. So part of medical respite requirements are that it has to be bed to bed. You have to be discharged from a hospital directly into the respite. So CMC, through our services at CMC, how I imagine this working is there's someone at CMC, they have been, our doctors are rounding. We always identify when our doctors meet with them, this is a person who's experiencing homelessness. They are going to be discharged to the DSS lobby or to Code Blue. And so what would happen is we intercept and we discharge them directly into respite. And maybe they're recovering from knee surgery or an infection that is caused by active drug use. That is a very common thing that happens where people that are in active IV drug use experience an infection. It requires them to have a lengthy hospital stay. More often than not, they do not make it. They check themselves out against medical advice, and then they end up whirling with a plethora of medical complexities. They're in the Code Blue system. We're not equipped to care for them properly. They're back in the hospital. They're high utilization. They're high risk. It will eliminate all of that. Did that answer it?
Kind of.
I love medical respite. Sam, we've emailed. I'm Jenny, the Commissioner in Whole Health. I think a great example, and I've worked with this before, is a lot of time it's wound care. So you might have somebody who doesn't need to be actively admitted inpatient at CMC, but they require additional wound care. And if it was someone who was discharged to their family or other caregivers, they would be able to help them with the wound care. But if they're in the DSS shelter system, Brittany and her team, they can't help with wound care. Right. So they sort of discharge them into this medical respite model where there is a medical provider, supportive staff that can help with wound care, or if it was like, recovering from a surgery or something like that.
See, and that all makes sense to me. I'm just wondering if are we considering the addiction to opioids a condition to recover from, or are we going to maintain that and treat something else? Do you know, does that make any sense? I'm having trouble.
So maybe we could reframe it like this is not a inpatient recovery for addiction. It is for medical needs for people that are experiencing homelessness.
Right.
Now, will they have substance use disorder? Maybe, probably, not always. So there's definitely people that are experiencing homelessness, do not have substance use disorder, have a medical complexity occur, and they have nowhere to go.
Right.
And so they would be great candidates for medical respite.
Okay. And then the hope is to maybe get them into some other type of recovery later, like a detox or something. And
Sure. And
Now
also, when anybody that is participating in respite services will have full access to our addiction medicine program, to our acute care, to behavioral health, psych management. So they'll have a lot of services teed up for them.
Yeah, that makes sense. Okay, thank you. Oh.
It's so nice to meet you. One thing I would love to talk about or consider in this is an opportunity for isolation. I think that is another really common use of this space is if you have, say, a measles case or something, or Mpox, and those are individuals who may reside in the shelter if they also don't need to be at CMC, and they could be discharged to respite to kind of maintain and carry out an isolation period there as well. So I'd love to talk more about that when the time is right.
Yeah, that sounds great.
Veronica?
You had something.
Yeah, if you're ready. Hi. 3 questions. One, 2 about the budget. I can't remember what one of them was. The $600,000 in funding through the New York State Department of Health Transportation Grant, is that the same as the ESHI grant you mentioned before? Or are you talking about 2 separate things?
No, that's separate from the ESHI. The New York State DOH $600,000 is a transformation grant that we've already secured.
Okay.
Will go towards the project.
You said you'd already secured ESHI funds as well?
We have, yes, and the ESHI will be used for support for the permanent units.
Okay, and then the budget we're looking at on this slide, is this all about the getting the building renovated and set up and running like prior to operations, and then operations are its own thing?
Yes. Mm-hmm.
Okay.
But because of our ability to leverage reimbursements for all different levels of care, operations are expected to be sustainable. Operation costs.
And to be clear, I didn't express it, I'm very excited about this. This is like awesome for many reasons that others already said. My last question is, why is it called Ross House?
Oh, we've gone around and around. Ross actually stands for the Roof of Supportive Services. That's not final, though. I think that's still up for debate.
Kristen?
Hi, yeah.
I just want to thank you as well. I was actually a social worker in the community when REACH started, and I can attest to what a model it is. It's actually been replicated in other places, New York City. It's an amazing initiative because not only does it bring human dignity and social justice to a population that desperately needs it, it also saves a ton of money, which I think you can show with your research, just how effective all of that is. And of course, these programs are just going to continue that great legacy, so I'm very excited to see all of that. My question for you would be, first of all, I have 2 questions. Are there any gaps or barriers that you anticipate the county needing to fill, and what would they be?
Right now, the one that is I don't know that it's necessarily a barrier, but it's a big risk for us as a nonprofit to be taking is we bought the building. So, because you have to buy the building in order to put in the applications, like you have to have site control. And so we had to kind of like take the plunge, sign the contract, and we were able to get into a lease to own agreement so that, because we felt like that's what would work best for us, is have a lease to own with a hard buyout date that would allow us time to do the underwriting for funding. So right now, Reach is taking out a risk of the collective rent that we'll have to pay, as like the building is just going to sit empty for about a year. And that's about $150,000, $160,000 endeavor that we're taking on as a nonprofit. And again, we believe in this model. We want to continue helping people. We want people to have better quality of lives. We want to improve public health, and we want to help our shelter system in our community by housing people and giving them a dignified place to recover when it's needed. So ultimately, Reach is Reach, and we were like, yes, we have to do this, but that is a financial risk that we're taking right now.
Okay, so, Mike, I'm just going to ask one more question. I'll punt it over to you. Okay, well, it's really good to hear a number. It's good to know that. And I think the other question I had is about growth. If you see the Ross House service expanding, and if so, what kind of commitments would you be looking for from the city and the county, and thoughts about cost sharing?
Yeah, I think that's an excellent question. We are, like I said earlier, it's been nearly impossible to determine the actual need for medical respite. There's been a lot of anecdotal hospital data, and because we have patients in these 56 counties, we're kind of connected and talking to them and talking to other people, but that is really hard to say right now. We feel like we have our thumb on the pulse in Tompkins County, which of course is our priority. So we understand the number of people that are admitted into the hospital at any given time, because we are the ones that are delivering services to them. As far as growth goes, I think most people in this room know that I've had a relentless dream about a campus. That dream is still very alive. It's breathing still. And I can envision us moving towards that once we better understand this model, the need. But, you know, growth is something that Reach is always doing.
Thank you so much. Yeah.
Mike.
Just a couple things. Well, the building right next door to it is open too.
Oh, great.
So, you know, that's also for sale.
Take it on.
Have you approached Webb and Kellis? Because I can't imagine this is a project they wouldn't want to fund.
Yes, they've both, yes, they're both supportive.
Supportive or supportive with cash?
Well, I mean, in the world of nonprofit, that's an excellent question we are putting in proposals to both of them, and we'll see.
Okay. No, that's cool.
But nothing concrete has been promised to us.
One of the reasons I invited Samantha and Reach to present today is because shelter housing is now part of HHS. And, last year we heard from Brittany on how the caseworker for families has made a huge difference in getting families into permanent housing and out of the THA and shelter housing. And we had asked Brittany to kind of give us an idea of what it would cost to hire somebody else, and what kind of savings we could see. And I think it was around maybe 30,000 would be an annual savings that we could see, and it could be more. I think Brittany erred on the lower end. But it's exciting to me because when we look at shelter services, when we look at emergency shelter services, I think that we are looking at this as the worst case scenario, and there are projects coming online. There's this REACH project. There's the idea of hiring additional staff at DSS to get more people into housing. In my mind, building shelter housing is a necessity, but what it looks like is determined by what we have in this community. And shelter housing is not transitional housing, it's not long-term housing. And we see taking folks from shelter and outdoors and putting them in permanent housing without services, we see what kind of issues that can happen. So my hope is this year in this committee, as we are dealing with shelter services, shelter type housing, looking at the emergency shelter project and understanding what's available, what's coming online, we can start to think outside of the box and say, look, if we support this, if we support this, if we get more staff to this county department, to that county department, what type of shelter services do we really need to provide? And my guess is there's a cost savings by supporting these other projects versus just temporarily housing people. We don't have any transitional housing really coming online, and that's a big next step. So hearing this before we hear the shelter project, understanding for those who are joining this committee this year, sharing about what's happened at DSS, and we'll do more of that. I think that we can kind of get out of this idea that it's shelter services, THA, or nothing, and figure out how do we support other Endeavor House, Sunflower House. How do we support these other housing services to take the strain off of shelter services, to get people into long-term housing, but not doing it by building the biggest shelter in upstate New York, right? This is Tompkins County. It's not even the biggest city in upstate New York, but we may be building as a county one of the bigger shelters in upstate and taking that money and doing other things with it. So that's an ongoing conversation that'll happen throughout the year. Sorry, Sam.
No, that's it. That's all I have. So,
okay.
Here's our timeline. Of course, it's subject to change. But I'm happy to answer any more questions if anybody has any.
Go ahead, Britt.
I don't have a question, but I can, is this on?
Yeah, sounds like
I don't have a question, but I can just add that at shelter, that it's helpful. We've had individuals who would have qualified for this service for medical respite, and it's important that Sam has already outlined that shelter staff are not medical staff, so they're not equipped to handle a lot of this. And so there are times when we have clients who are released from CMC because CMC doesn't have a reason to hold them. And so they're released back to shelter. But then if the needs in shelter, like the medical needs like wound care, or if the client starts to deteriorate, if things are beyond the shelter staff's ability to do, then they get sent back to the hospital, which Sam was talking about with that readmission. So it's just like this circular thing that we're just fighting right now. So medical respite would be fantastic for individuals who are not appropriate to be in shelter. To recover medically.
Yeah, and I think it's this natural complement too, because there are specific requirements that come with medical respite, and that those requirements will also serve the entire population that is permanently housed in this building as well. So they will have access to reach staff 24/7. It will look very differently than the way that I think we've seen other supportive housing initiatives look in Tompkins.
And the 10 units that are for the permanent housing, my assumption is that we're talking about 10 folks that are pretty challenging and present some difficulties to work with, which puts a strain on the shelter system and the hotel system to begin with. So if you're housing folks that have had more challenges in the past, that does free up some staff space, staff time to work with other folks.
Absolutely, yes. I think with the high level of staffing and support and supportive services available, we will be targeting some of our historically most challenging individuals to house.
That's great. Any other questions for Samantha? All right, Sam, thank you. We'll probably be inviting you back to share how things are going throughout the year and seeing if we can help meet any of the needs that Reach has. Mike?
Actually, just one last question. When would you need this funding? I mean, it sounds like you're going to start construction 12/26.
Yeah. And so, and a lot of, obviously a big portion of this hinges on HHAP funding being granted. So I think that would be a really, like Travis said, staying in touch and letting you all know how the developments are coming along. And then we'll have a better understanding of specific numbers and needs.
Cool. Thanks.
Thank you so much.
Thank you. We will hop over to the county administrator's report. We have two topics, the 2026 department goals. We split that up so there's So some goals will be shared this month, the rest of the goals will be shared next month. And then there is the emergency shelter project, and then we'll go to whole health and then DSS, so you all can get out of here and get back to a few things, and then we'll do the sharing with the other departments right after that, if that's okay. So who is here? Is it Bridget? Or is Corsa?
Hi, how are you?
Good, how are you?
I'm good. I'm wondering if we may be able to do the shelter presentation first, given we have some guests online to do that presentation.
Absolutely.
Wonderful. So we have here Monica McCullough, who is our consultant partner in this project, and we also have the team from Plan Architects as well as Volunteers of America. So I'll turn it over to you, Monica, and you can kick us off.
Hi, everybody. My name is Monica McCullough. I am a developer based in Rochester that has been engaged by the county to assist with the development of the Cherry Street Permanent Emergency Shelter for adults. We have presented at the full-fledged meeting, and we have recently presented at a public meeting and wanted to provide an update on where the designs stand for the project. This is going down an HHAP path as well, anticipated for a funding application this early summer and award in October. This is a front elevation. This is slightly updated from the plan that folks may have seen earlier. The physical kind of design of the building, it remains the same. It's kind of intended to fit into the kind of light industrial nature along Cherry Street. One of the challenges with this site is the elevation and its location in a flood zone. That will require the building to be stepped up, which is what has been incorporated into this elevation, and you'll see in some of the other plans. So the building itself will sit up on built-up soil and will have to have a somewhat complex series of ramps to ensure accessibility up to the front and around back. This is a view of the front of the building from Cherry Street. The front has kind of a porch and an overhang. That front building looks like a front entrance. It won't be the primary entrance for residents. I'll show you where that is on the next slide, but that front overhang will provide a seating area. It would be an area where residents could meet with providers or, kind of have some space outside if they need to. This slide is from the rear of the site. It shows what we anticipate to be the primary entrance for staff and guests in the building, which is under this kind of overhang location here. There's some parking, which we'll see in a site plan soon, some bike parking, some outdoor area. This is a view of the exterior courtyard. This is a private space where residents would be able to access, some outdoor fresh air, peace and quiet, both kind of open to the sun and also protected by this overhang with some kind of stadium style seating. Again, that is included in the plan to kind of work with the elevation of the site, but also to provide some kind of low, kind of like simple, basic, but also kind of nice and interesting seating area for people to relax outside. This is a copy of the site plan of the project. This is kind of the front Cherry Street entrance. And then the layout of the building, which includes a pretty large turnaround. The turnaround is necessary to accommodate both visitors and staff, but also any emergency visitors to the site, because this portion of Cherry Street is a dead end. So that has been important in the site planning process. This shows kind of the ramp up to the front that we saw on the front elevation, and then also the parking, and then some additional parking to this kind of main back entrance. We anticipate that the site would be kind of fully fenced. And then this is the courtyard, which would be enclosed for privacy of residents and security of the building. So that's the kind of exterior site I don't want to rush through too quickly. If there's any questions before we get to the floor plan, anything that I could address now before I keep going?
Any questions so far? No, it doesn't seem like there's any.
Okay, great. All right, so this, it will look kind of similar if folks have saw the earlier presentations, but the floor plan here, this is the intention where residents are coming into this kind of secured overhang, secured vestibule, double entry with, you know, kind of a staffed security type presence at the front door, the ability to do resident intake, you know, immediately as someone comes in, and then some space here, which we are showing on the plan as a meeting room, but this could be a secondary intake room. We've also had conversations about ensuring there's space if a resident needs a private meeting room or needs to take a telehealth appointment. So there's some flexibility in how this space could be used in the building. There is a suite here off the center, which would be used for building staff. This building will be staffed 24 hours a day, 7 days a week in accordance with New York State shelter regs. So this space here is office space for a director and other staff, private from residents. There's an area here which is kind of overflow resident storage, which could be programmed in a way to provide some space for storage of belongings above and beyond what would fit in the tenant's individual storage, which we'll talk about when we get to the upper floors. There's a central elevator and a central stair. So this building has an L-shaped design, which is intentional for kind of visibility on each floor as we get upstairs. A building of this type has to have two what I would call code stairs at the end of each hallway, which would be fire rated, enclosed. We added a third stair, which would be open, brighter, and hopefully accommodate and encourage circulation of the building from a stairwell, in addition to just using the elevator to get up and down. So that's located in the elbow of the building, right next to the elevator. There's some restrooms on the first floor. There's some kind of back of the house, mechanical space, laundry space. There are a series of offices that would be used for both VOA staff, but also some drop-in, what we're calling push-in space for providers in the community, such as REACH, such as other providers who would come in on a temporary basis for specific programs, or maybe have a more established relationship with VOA. So there's an opportunity for non-VOA program office space in the building. There is a full commercial kitchen, storage related to the kitchen and operations, cafeteria type room for meals, and then an additional community room that we are kind of showing with a bank of desks and computers, but could be programmed a variety of different ways based on, you know, the interests of the residents. So this first floor is kind of the main hub of the building from an activity and services perspective. The residential beds are on the second and third floor. So VOA has a specific emergency shelter model that includes both open bunk style living and then individual rooms. So the second floor is programmed with bunk style housing beds that we have organized by furniture into kind of little pods, but this remains kind of retains site visibility down each open corridor. There is laundry facilities on each floor that are available for residents. There are bathrooms on each floor. There is several staff spaces on each floor. There's a case manager office in the elbow. There is an individual who would be kind of more on the floor. There's two desks for that, one here and one in the middle. There's some linen storage and trash storage area, that central elevator, and our circulation stair. Each living space would include a bed, which these show a mix of kind of single beds and bunk beds. and then a kind of dresser and storage area that residents would have for their personal belongings that would be locked and secured by them. So that's the second floor. The third floor has a similar layout, but it has less beds. The beds on this floor are also a mix of singles and doubles, but they're in individual rooms, so a little bit lower density. This style of having open bunks and single rooms allows a mixed flexibility in terms of kind of housing the number of folks that we intend to, but also allowing some flexibility in terms of who may need an individual room for a variety of reasons. And also VOA implements kind of a graduation approach to moving people who have been in the shelter for a while from the bunk up to these individual rooms, and a progression approach to kind of move out ideally into permanent supportive housing. So the overall count here at this building, it can accommodate 80 beds on a square footage basis. That is a bed count related to shelter regs. So that would be the maximum number of people that could be housed in this amount of square footage and support space. This is an exterior elevation. Not quite as cool as the first elevations we show, but essentially the same thing, showing the rear entrance, the windows, the kind of need to address the elevation on the site. And that's it from the building design perspective. In terms of timeline, as I said to start, we're planning on submitting to HHAP in this year's round. We anticipate that funding awards would be out approximately October. The shelter design process will take a while. We will have to follow county requirements for bidding and construction, which will add some time to the process. And we're also working around just being mindful of the existing building, which is being used for Code Blue. So the intention is that existing property would be used for Code Blue in both the 26-27 winter schedule, but also the 27-28 season, with construction on this building starting immediately at the end of the 2028 Code Blue season, which would put us, approximately early May for a construction start if we were awarded this fall from HHAP. So that's what I've got. I'm happy to address questions or anything else that I didn't cover in my spiel here.
We have Christy, Rachel, and then Veronica.
Thank you so much. This is very exciting to get to this point and see the plans, and it was really thorough. The question that I have is about ADA compliance. I think currently we have to put folks in hotels because what we have is not wheelchair compliant. Can you speak to that in these plans?
Yeah, absolutely. It was a big focus on the public meeting that we had earlier this week. So this building is ADA compliant completely from a regulatory perspective. I think we're diving into kind of a richer understanding of that as we've been evolving the design process based on aspects of accessibility that may not be, kind of black and white in regulations. But in terms of, this building being accessible, yes, it is accessible everywhere. We will have accessible bathrooms, all of the support space, everything is accessible throughout.
Perfect. Thank you.
You're welcome.
Rachel?
Thank you for the presentation. I have two questions. The first one is about the funding. So are we sort of in a holding pattern until we know how much of that HHAP funding we're getting? I imagine if we didn't get it or got us, I don't know if it's an all or nothing thing, but I imagine we might reconsider the design if we didn't have that funding coming in.
Mm-hmm. Yeah, it is an all or nothing application process. So yes, I think, similar to the project that you heard about before this, HHAP is the heart of the capital. I mean, certainly the county can supplement that, and that is part of the plan. You've purchased the building and have some costs already anticipated to be covered. But HHAP is a great source. So You could, if hopefully we are successful with the application this round, but if it's not successful, you could fund it a different way. You could shrink it, or you could go for another round of HHAP based on their feedback.
Okay, so we're not moving for, I mean, maybe this is, I don't know, maybe this is a question for someone else, but we're not actually moving forward on this until we know where the funding's coming from? Is that right? Okay. My second question was, you talked a little bit about the graduation model, which I know you talked about at the public meeting too, where you start on the second floor, and then if you have been there for a while and maybe you have a job or you're stabilizing and successful in the shelter, that you would move to a private room on the third floor. And I was wondering if there's an opportunity to have that be like a more structured transitional housing setup on the third floor, or if that's not something that's really mixed with shelter housing.
Yeah, I think from an HHAP regulatory, well, I guess from a shelter reg perspective, I don't know that you could necessarily commingle transitional housing beds in a shelter bed. We have talked about the potential in the future to making that third floor, because it's already set up as rooms, it's come up related to transitional housing. The trouble with transitional housing is there's very little identified ways to operate that from just a subsidy or grant perspective. You have per diem that can support emergency housing. There's programs like eShy that can support permanent supportive housing, but transitional housing as a model, hasn't been funded in the same way. So when we were approaching development of this, there was no identified way to fund transitional housing on that upper floor separate from the emergency shelter, but that doesn't mean that it could never happen in the future. It may not be an easy switch, but from an HHAP perspective, their capital can be used for homeless housing, period. So as long as the residents are coming in as homeless, it could be emergency housing, transitional housing, or permanent housing from a capital regulatory perspective.
Okay, that's helpful. Thank you.
Veronica?
Yeah, thanks. Monica, thank you. I know I got to ask you some questions on Tuesday. I have new ones.
Okay, I'm ready.
About this being in a floodplain, you talked about the building having to be just raised up a little from the ground because of that. And I don't know if I missed other things, but I had a constituent concerned about this, I guess, suggest a couple things, which I'm going to ask about, which are, or I don't know what my question is. Let me throw out this person's suggestions, which is incorporating other flood resistance measures into the design, which could include having the electrical utilities not be on the ground floor, which I see that they are, I guess, understandably designed to be right now. Using waterproof drywall alternatives or similar products on just the first floor, doors designed to seal to keep out floodwaters, and or other floodgates, flood shields, things. Is any of that in your thinking process? I know some of this is material stuff that wouldn't have come up.
Yeah, so and Mark, I think if you're still on, I'll start this response and then let you finish. The regulation or the local city obligation to work around the flood zone is to physically raise the building above the floodplain level. So the height of the building, it's more than a little raised, it's a lot raised to be up above that water level. So the physical buildup of the full building itself is what lifts it above the water. So the variety of things you were talking about would assume that water is getting into the first floor. The base kind of concept here, workaround, is that the full building is up above that floodplain itself in whole. And Mark, maybe you want to expand on that?
Yes, so you're absolutely right. So we're being told by the engineers that the first floor of the building will be set 2 feet above the base flood elevation. So with that said, the intent is that the first floor would not receive floodwaters because it's 2 feet above what's considered the flood elevation. So there's really no need to make assumptions that the first floor is going to accept floodwaters and then go through the process of special drywall and other materials, because the intent is that the entire building is 2 feet above the flood elevation.
That makes sense. Thank you. How high are we talking of the ground level that's there or will be post-construction?
Yeah, so we're being told, based on the elevations that we're getting from the engineers, we're approximately 6 feet above. If you're standing on the site right now, the first floor elevation, floor level would be 6 feet higher than what's there now.
Okay, thank you. And then the other thing from the same constituent who is a former solar panel installer says that it's cheap to add the conduit for a potential future solar installation during the construction in case one wants to install later. Just throwing that out there.
That's true, and we should. And Mark, if we don't have that, we should. But that is true, and we should be doing that so that if there was any interest or funding or specialty way to add panels later, that was all prepped. So yes, agree.
Brittany, this question is more for you. In your assessment, and I don't know if you've had time to do this, and if you haven't, please, feel free to say so. Once this is completed, if it's completed as designed, what would be the county's reliance on hotels moving forward for THA?
Yeah, so the reliance would be less, but we're still going to have to rely on hotel placement. So there will still be individuals who cannot be placed in shelter for one reason or another. Families won't be able to be placed in this shelter because this is only for adult individuals. So we'll still utilize the hotels for families. And then there's legal reasons that someone couldn't be in the hotel or in the shelter. So if they had a restraining order was against someone that was there, they wouldn't be there. If they have a significant accommodation that the shelter can't support. So the hope is that building this shelter and getting the feedback from the community, having these presentations, is that feedback is going to help with the design process as it moves forward, so that that it's built from the perspective of accommodating the community need now as much as possible, so that reliance on hotels is less. But we will, in the end, still have to rely on them for certain individuals and families.
There's a part two to that. Do you think maybe April, May, June, it's not a rush, you would be able to kind of give a guesstimate to what it would still cost us yearly for THA housing?
Mm-hmm.
Cool.
You can do that.
All right, Christy?
Great. I just have a general question. Is the shelter, Cherry Street shelter, on the TCAT route? I don't know.
So, no. So there's stops nearby, but we are actively working with TCAT, especially with the new shelter build, to work this issue out. So TCAT's been
To get
coming
it
to the table.
directly on the route one day.
One day.
It's 2 blocks from Wegmans. So.
Yeah, so Wegmans, people get on and off there. Art House, people get off there if they request it. But there's still active communications with TCAT. They have already said they're willing to work with us on this.
Any other questions? All right. Well, thank you for coming and making some time for us today and sharing the update. It's very helpful information for us. Thank you. Bridget, I'll turn it back to you.
Great, thank you. I think just to summarize that presentation, we do have a web page dedicated to this project on our county's website. You can easily access it. It's under Emergency Shelter Construction Project. It includes all the visuals that were presented today, basic information on the timeline, project cost, etc. And we'll also be sure to link this presentation to that site so that folks can watch this and continue to provide input. We are still looking for input and happy to take that as this project continues to develop.
Thank you. Mike?
I actually have a question for you, Travis. I mean, sounds like the building, that was great. The functioning of it, I mean, that discussion has obviously started and it's ongoing. Will that be more of a focus going? I mean, I guess it would be, right? Would be more. I'm like, how long can someone stay in the shelter, for example, until, or do we move them out to other, and are we going to set metrics for that, or?
I don't know. My guess would be, and this is a guess, when St. John's was running the shelter, there was people there like it was permanent housing. There was people there for a long period of time. I think that would be, if VOA was our partner, this would be kind of be determined by them. I mean, I think my hope would be, and I don't know if others feel the same way, is that VOA will kind of establish what this looks like if they're the ones running the shelter. Like, we wouldn't have to manage those pieces. I think between the folks at DSS with Brittany, they would look at VOA's plan, work out some things with them. But I think, and Brittany, please chime in, I think a lot of that would come down to VOA and how they run the shelter if they were the partner at that time, which seems to be the hope.
Yeah, VOA came on as our shelter provider for this project specifically, so they will run the shelter as they do their other shelter operations.
Okay. I should have asked that question. Sorry.
Can I speak to that?
Don't be time.
I'm going to give my social worker perspective on this. So a shelter exists, it addresses a symptom of a larger problem, which is an affordability problem. And so people cycle through homelessness because they can't afford permanent housing. So that's why a shelter doesn't cure homelessness, right? So it's why we're always looking at how can we make more and more affordable housing. So I don't know if that helps with your question.
Well, it's just if you fill up the shelter with people that are going to live there permanently, then it's no longer a shelter. Then it's permanent housing, and then you have to already be thinking about the next shelter you're going to build. See my point? So
I do. I think it's, so much of what we're trying to do here is come up with more affordable housing options to prevent the chronic homelessness. And so I don't think it's, to Travis's point, it's not about building more and more shelters. It's about being smarter and more strategic to offset as much of the human suffering and cost as possible. But to me, the greater question is, what can we do to create more affordable housing?
I think I can help your thought.
just if I could make just an observation or suggestion too, is that, and that is true, but that's not really how I see the purpose of the shelter. I see the shelter as getting somebody off the street and then getting them some services, and then maybe letting them stay long enough that we can prepare them to live in a different situation, like an SRO, and then from the SRO, maybe then they can get Section 8 housing and into an apartment. So I do see a number of steps. I do understand what you're saying, but I think the shelter serves a very specific kind of role. I don't know if people agree with that or not, but that's kind of how I see it. But. Brittany?
I can speak to that. So there won't be permanent supportive housing or transitional housing right now is not in that plan for the shelter. And VOA services heavily focus on getting them to be able to go into permanent housing and to get out of to move on from the shelter. So that is something that VOA's staff and their training model, their philosophy model focuses on, and then DSS will still work with them work with VOA in the way that will also support that housing piece. So right now, our case managers for DSS work on site with individuals to connect them to housing. VOA has staff internally at the shelter who help with that initiative as well. And so once the shelter is built, then DSS and VOA can work together. So perhaps VOA is the one that is helping connect them to housing, and then the DSS case managers are the ones who are providing that ongoing case management after they move into housing to keep them in the housing. Right now, the DSS staff are kind of doing both of those pieces. So having VOA come on board to support with the services and everything that's provided at shelter to move them into permanent housing is going to be incredibly helpful. Is that?
That was very helpful, yes.
Okay.
I think the question too, and maybe Liddy has the answer, maybe Brittany has the answer, is how many SRO units even exist? Because if you're moving folks into an SRO unit and you're waiting, I mean, that's part of the holdup, is having enough of those type of housing to move people along in the system. You know, if as an adult single male with no kids that are my dependents, well, my 23-year-old thinks he is, but I don't know how much I qualify for rental assistance. And I certainly probably wouldn't qualify for an apartment, a one-bedroom apartment. So that's probably part of the problem we have in this community is the number of SROs that exist. Is there enough for the population? The answer, I'm assuming, is no. So what do you do with folks that don't have the finances to move into an apartment, and what they would get from a voucher from DSS certainly wouldn't get them into a one-bedroom unit. So that's part of the problem that we have, is the units being available, being able to move people through the system. So that's why people end up in shelter services longer than anybody would like, because we don't have a place for them to transition to. So that's why one of my thoughts is, as this body, how do we become more creative in looking outside of that box for those type of solutions, so we don't have somebody in the shelter for 6 months. We have people getting those services, getting the help they need, and then moving on to the next, and then going from transitional to permanent housing. So I think that's where the bottleneck ends up being, is having enough of those units. For years, we talked about some of the places where people had to go that were, they weren't fit for people to stay at. I won't mention, those buildings, but there were big concerns, and that's where folks had to live if they had an SRO, in places that none of us would want to live in, and it was challenging for folks. I have people that would intentionally violate parole to go back to prison instead of staying at some of those SROs. So having quality SROs, enough SROs, I think that's a big deal for people to be able to move through the shelter system.
Yes. And I can add that right now our average length of stay for adult individuals is 80 days, and for families it's 65 days in THA. Okay. Hope is to lessen that.
Bridget, do you want to hop to the departmental goals?
Sure, great. So I believe, Travis, you had requested to hear from maybe just a few of our departments at this meeting, and then the remainder of the departments at our next meeting.
Yeah.
So I have asked those departments, which include Department of Social Services, Whole Health, and Veterans Services, to be prepared to talk through maybe concisely the goals that they've submitted, and then you're welcome to ask any questions that you may have.
Okay.
So Brittany, why don't we start with your goals?
I didn't bring anything. I submitted it. So are you putting it up?
They're in the packet. Do you have access to the packet?
I mean, I know what mine are. I just didn't know if everyone had.
Oh, yes. They're included in the agenda packet.
Okay. Okay. So our goals, they're really foundational and focused and intentional, and with thinking through the goals with my senior leadership team was really, what did the department need? And we felt that these 4 goals would really help set the direction for the department. And I think, what's important to think about when we set the goals for the department is that it was the first time that senior staff had been involved in setting the goals, and this is the first time that the department as a whole, that staff will have engagement in the goal realization process. And in thinking through the goals, the reason we kept them so small and intentional, the reason we only have 4 is because I think the department as a whole has just been fighting fires since I've been here, since July. And it's been, it's driven by high pressure and crisis driven environment. So I think keeping the goals small really allow us to be have intentional action, measurable impact, and to just continue the work even when we have all this other stuff going on. So the first goal, we have defining our mission and our vision and our values. And this is a goal that started in 2025 actually with staff input, and it's a goal that's going to continue in 2026 to define and finalize that. And what this does is it's going to provide a framework for consistent and values-driven decisions and a culture in the department. And that is going to align staff, promote accountability, and support shifting some of the internal culture that needs some shifting. And this aligns with the county's strategic priority of organizational excellence. And then moving into goal number 2, or actually let me back up. So on the mission, the vision, and values, one question that I kind of got was, the county has a mission and they have values that exist. So why develop this for the department? And I think the county's mission is broad, and the department's mission and vision and values is specific to the department. So it's going to ensure that we have consistent decision-making, that staff feel like they are part of creating these and defining these, and that it really promotes the department focus while still aligning it with the county's broader structure. So moving on to goal number 2 was the equity indicators. So when we were thinking about these, and up to this point, the equity indicators have been focused on staff and training, and what we want to do is shift that focus. So previously, our equity indicators tracked the number of staff who were participating in trauma-informed care training, and also tracked the participation in a work group that was really focused on diversity, equity, inclusion, and equity indicators. And now the department training for that trauma-informed care is just embedded into the department. So it doesn't feel, what is the word I'm thinking of? It doesn't feel like that is a good thing to track anymore because it's just embedded in what we do. So it's a requirement for all staff to complete. So our focus here is the shift to measuring client experience, access, and outcomes, and to move what we're tracking to really focusing on client impact. And I think that's really important for staff because they see things all the time on the ground. They're the boots on the ground. They're the ones who have the feedback, and they're the ones who understand how all the different data systems work. And I think something that is confusing to outside folks and frustrating for department staff is that the data, there's so many different data systems for the state, and trying to understand how they all work and how different data points make either work together or work against each other. I think bringing staff into this conversation was so important so that we can have those voices, and then they can also help move this goal forward. We have already also started working on some of this goal. Staff already started looking at updating our phone trunk line. If anyone's called DSS, you understand how frustrating it can be to get through that. So staff have worked on updating just when you call what the menu options are, how you access different things, and then that will be tested with clients. We'll have clients call and experience and give their feedback on that line. And then our third goal is to develop a department-wide policy manual. So currently, the department doesn't have a centralized department policy manual. There are some inconsistencies across the divisions, and that can cause confusion among staff, or some staff will say, well, that's not the same for this unit or that unit. And what we're looking at is taking the policies that can be extended across all of our divisions and our units and making those department-wide policies, and then keeping the unit ones specific to their units only. I think this is really going to help with consistent practices, providing clarity to staff, reducing conflict, and supporting accountability and risk management. And then our last goal is our external communications plan. So a lot of feedback that we heard is that the community, our partner agencies, the individuals that we serve, the legislature wanted more information from the department. They want more on our data. They want more on what we're doing. And I think this is going to help us make a plan to respond to all of that. And one of my hopes out of this goal for the year and what we're tracking is launching a newsletter and an annual report. And the reason this external communications plan is on our goals is because it's going to help increase transparency and trust and just understanding of the department services, our outcomes, and the feedback that is given, or the feedback, but the information that is given to the community.
Well, you had me for the first time, the department as a whole was working on the goals. I was really excited, so I've kind of been up here the whole time you've been talking. It's really exciting to hear those goals and see and feel this shift. Well, thank you for sharing. Is there any questions for Brittany? Veronica, then Rachel?
First, seconding Travis, that's fantastic. I feel like the staff should always be involved in setting the goals, other staff than just the department head. And also really happy to hear that you've got frontline staff involved in some of it too, because I get that in a department as big as yours, you can't just have a department meeting where everyone shows up and makes decisions together. I have a question. One of our committee goals was about establishing a DSS advisory board, and I know you were going to update us on progress with that. I don't know if that was this meeting or next meeting, but how is that also part of it feels like it's dovetails with the external communications goal. I guess, can you just speak to that?
Yes. So I will say that the hysteria crisis happened and the advisory board fell to the bottom of my bring an update on that. So if we can put that back on for the next meeting, I'd appreciate it. But yes, that is still something that we will tie into the external communications.
Is that something you would like to do next meeting or in May? It seems like hysteria is not going to go away anytime soon. And I want to give you the space and opportunity to work through things. We don't have to do it in April. This thing may go on to the beginning of April. So you don't have to decide today. You could let me and Jordan know when you want to do it, but
I'm thinking of it being, it's already March 12th, whoa. May is probably better, thinking more so of my staff. I can always, figure my own stuff out, but thinking of my staff and how much work they're putting into numerous things that are happening right now, I think that would be helpful.
Yeah, that's fair. That's good.
Thank you.
Yeah. Rachel?
I agree. These seem like really inspiring goals, and they're exciting to think about. For goal number 2, it also seems really great that the focus is on client experience and outcomes. And I'm curious what mechanisms you plan to have in place, how will you be able to hear from clients about accessibility or experience or kind of outcomes?
Yeah. So the first, we have tasked senior staff with being the point. We have tasked 2 senior staff with being the point person for each goal, and so one of my deputies and one of my other staff who do all the data, they are leading as point people on that, and we will center that client experience either through surveys, through being out in the community and holding sessions, and potentially doing things right at DSS, so that we have a roadmap that the senior staff have developed internally, saying okay, at this point, where are we? Are we at least where we kind of want to be right now for every quarter? And staff are working on how to roll these goals out on some of them. So we do have that roadmap, but that point is not entirely clear yet because they have started to develop the equity goal that they think they want to launch. And again, the struggle with the equity goals for the department have been that we work across so many data systems and they're so separated from each other. So getting staff and getting the staff who use all these systems together to really define that, I think, is the piece that has been missing up to this point. So it really is going to be the work group, and I can report back at the next HHS. They're having sessions next week for staff. So
Thank you.
Christy?
Great goals. You have a huge amount of work on your hands. I think I don't need to tell you that because DSS is so complicated and the caseloads are so incredibly heavy. The goals are mostly, if not all, administrative. I would just like to bring up the, burnout in staff and maybe focus a little bit on what the department is planning on doing for staff well-being, staff retention, and specifically burnout.
yeah, so the department is well aware of this. Part of the ask for staff to participate in this and participate in the goals is to give them a voice and to give them the ability to help direct or help our direction. Like, what direction are we going? It's going to depend on the staff involvement. In terms of the well-being, so unit directors specifically, so the ones who oversee the different divisions in the department, they are working hand in hand with their supervisors and their staff to address things that are happening on their specific unit, because each unit is pretty different and separated. And there have been numerous initiatives to start addressing some staff well-being, and I think that we'll start to see some of those changes as they roll out. It is true that the department experiences a lot of burnout. It is true that we're short-staffed, and that is stuff that we're still thinking through with our staff. One of our units is about to roll out, the supervisors are about to roll out a survey to all the children's services staff that is addressing this well-being issue, so that we can start looking at that, right? Because if we don't have staff who are healthy, then we're not going to have clients who are healthy, we're not going to realize our goals, the department suffers. So it is something we do take seriously.
Kate?
I just wanted to kind of address that a little bit too, because I think sometimes the expectations about how department heads raise morale in their department, we're looking at low cost or no cost, because we're really limited in what we can do financially to bring in lunch or to do things that would be more appreciative. So what she's laying out are things that I think all department heads are trying to do. She's obviously struggling with that, and so will Jenny, because they have large departments. But part of what we are based on in our performance review is like, how are we keeping the morale of the departments up? But I just want to make sure that we're being clear about the fact that if department heads spend like their own money to do some of those things, and so they really are working, and historically and other department heads that are no longer with us have done the same thing. So I just want to be clear that like we're really all working within our departments, but it can be hard sometimes to do the larger things that you're seeing because it's coming out of our own pockets. If we're doing it most of the time, we aren't able to necessarily do because of the restrictions for the financial stuff. And I just think that that's a really important point to bring up, because it's something that a lot of department heads talk about a lot. So.
Thank you, Kate. That is important to recognize. We deal with that a lot on the city side of things as well. Brittany, while you're there, instead of circulating back, do you want to do any sharing?
So much is going on, Travis. I think if you guys don't have specific questions about things right now, I think for time, I think we're okay. I've had a lot of conversations with each of you.
Mm-hmm. All right, Jenny, you can go next. After you're done with the goals, we can go through your resolutions and get you out of here too.
Great.
Brittany,
all right. We have more goals than Brittany. We sort of had a fun, like, how many goals are you making? So we have 4, the way we structured our goals is we have 4 goals that are internal looking, that kind of focus on the work that's happening within the department. And then we have 4 goals that are a little more things that are happening outwards in the community. And we might be working on those in collaboration with sibling agencies or community partners. And then we have 2 equity indicators. I set these goals with my senior leadership team, which is division directors and other senior roles from across the department. We really tried to look, and I specifically tried to look back at the existing documents that govern our work. We have currently a Tompkins County Whole Health Strategic Plan, We have a local services plan, which governs our mental hygiene and mental health work. We have a CHA CHIP, which is the Community Health Assessment and Community Health Improvement Plan, and then there is the Tompkins County Strategic Plan. So as we developed these goals, I crosswalked all 4 of those existing plans that we are also accountable to make sure that any annual goals that we developed roll up to and feed into these other larger existing documents. We focused on making sure that our goals are in service to the community, that they are in pursuit and realization of our mission, that they are things that we truly think are achievable within the next year, and then we sort of, use the SMARTY framework to guide those specific, measurable, achievable, relevant, time-bound, inclusive, and equitable. So our first goal is internal, and we'll talk more about this in my updates. This is around realigning public health services programs to more closely reflect evolving community health priorities and further strengthening integration between public health and mental health services. Our second goal is sort of a similar one, which is a look at mental health services to identify if there's any needed changes in scope, focus, or workforce practices that really look at strengthening workforce resilience and advancing equitable, person-centered, integrated substance use and mental health care. Our third internal goal, we have several values at Whole Health. They are compassion, integrity, respect, excellence, equity, and stewardship. And so this goal looks to embed those values more into our departmental operations rather than just kind of have them on the posters around the building. Let's really bring those in-house and think about what those look like and how those show up. One way that we're already doing this is using these values to guide a new performance review process that we're taking on this spring, so that when folks go to do their annual performance eval, the questions are kind of centered and rooted in these values. So that's another internal goal. Our fourth internal goal is around safety and security. This is one that also is reflected in the Tompkins County strategic plan. So really around enhancing an organizational culture of safety and security, including psychosocial safety through the development and implementation of trauma-informed policies, comprehensive staff training, and really making sure that all personnel are equipped to effectively manage safety concerns while continuing to uphold the dignity, trust, and equitable treatment of individuals receiving our services. Our external goals, the first one is around improving access to integrated prenatal and postpartum care. This is also one of the main areas of the CHA CHIP that will guide sort of some of our health planning for the next couple of years. This one focuses on integrating mental health and nutrition services for birthing people in Tompkins County, and there's sort of a specific piece here around increasing postpartum visits by 5% for all of the whole health perinatal clients. Our sixth goal is around deepening collaboration with sibling agencies by establishing or strengthening at least 3 partnerships that align with shared public or mental health priorities. One of these is underway with Kate's team and Brittany's team, and we have staff that are all part of this Empire State Leadership Group that are meeting and kind of working on a shared project together. Our seventh goal is to establish and launch in partnership with key stakeholders a multidisciplinary suicide and overdose fatality review board here in Tompkins County. We have a white paper on this at the moment, and we're starting some outreach with a couple of different key community partners, and then we'll roll this out a bit more publicly and talk about how to bring this to fruition. Our eighth goal is a little more focused on our environmental health work. This is also specifically found in the Tompkins County strategic plan as well. It's looking at evaluating opportunities to strengthen local water protection by proposing updates to the sanitary code, expanding septic system support, and improving resiliency for residents on non-municipal water. We're also in this goal talking a little bit about expanding outreach efforts related to harmful algal blooms, and you'll recall that we got a grant to do that work this summer. Really ensuring equitable access to clean and safe drinking water and water recreation opportunities for our community. And then our ninth goal is looking at trying to come up with an implementation plan. This one's a little bit more of a planning goal for a school-based oral health program. Pediatric dental is a really big gap in our community. It's surfaced in several spaces. It shows up in our CHA CHIP plan. I think this also links back to the county strategic plan to bring services and resources outside of downtown Ithaca into the communities. So we're looking to come up with a plan on how we could really expand preventive dental services. We've actually already launched a survey in partnership with Cornell, who's doing a qualitative survey to assess parents' experience trying to access pediatric dental services for their kids in the county. And then we have 2 equity indicators. Our first one is around expanding recruitment pathways and building a stronger workforce pipeline so that new hires more closely reflect the racial, ethnic, and linguistic differences, racial, ethnic, and linguistic diversity of the community. We're doing this through some expanded partnerships with educational institutions and community organizations, and then also taking a look at our hiring practices and trying to bring some standardization and anti-bias practices into those. I think our hiring practices and interviews is another place where we'll be looking to embed our values and really making sure that we're asking questions that kind of promote those values as part of those interview processes. And then our last one is sort of deepening our community engagement by really formalizing and sustaining partnerships with community-based organizations and really looking to provide some sort of technical assistance and capacity building. I think a great example of this work underway is the program that you've all heard about in the past, where we're supporting the opportunities for a doula training for individuals who are coming in and out of underserved or underrepresented communities. And so that's one where we've really been sort of a technical assistance and capacity builder support, but we're not necessarily leading the work. So those are our goals, and I would be happy to field any questions.
All right, Jenny had 9 goals, 2 equity indicators. It is 11:40. So when you start to ask your questions, just be mindful of the time. Questions? Comments? None? Well, I guess you don't have to be mindful of your time. Jen, you got, somebody? Nope. Jen, you got 2 resolutions. 9 is a lot. That's a heavy lift.
I mean, I think a lot of these things are things that we knew we were going to be working on. And I do believe that in some capacity, there are things in here that are achievable for each of those goals. That was important to me. It frustrates me when you set goals that take 3 years to complete in a 1-year timeline.
Well, it's exciting that to continue hearing the forward thinking and the community-based planning that you all are doing. I love it. I will go with the resolution for authorization to accept children and youth with special health care needs, CYSHCN funding, and budget adjustment, ID 13931. Do I have a mover? Veronica moves, Christy seconds.
Yeah, so this is a program that is sort of, it's going to work in partnership with our community health workers. So it'll fund part of a role to do sort of coordination and referral and connection for services. It really looks to support children and youth from birth to age 21 that have special health care needs. This could include chronic illness like asthma. It could also include individuals living with developmental disabilities. And this role helps, this funds helps a role which can help families navigate special education services, help accessing health insurance, and then help families find items and services that might not necessarily be covered by health insurance. So it fills out our community health portfolio.
Any questions?
Community health worker portfolio.
All right, ready to vote? All those in favor? And that is unanimous. The second one is authorization to accept dual settlement funding and budget adjustment whole health department, ID 13930.
Yeah, this is another one that we're going to be bringing in.
Wait, do we have a mover? Veronica moves, Rachel seconds. Thank you. Thank you, Veronica.
Yeah, these funds we're really excited about. We have long had someone who's been working in sort of tobacco prevention, particularly with youth. She's had, actually the role is vacant right now, so we're looking to hire, but this role has typically worked really closely with BOCES, with the school system, done a lot of education. They did a Find Your Focus, Not Your Fix, really wonderful marketing campaign in the last couple of years, so this will just help us continue that work.
Any questions? All ready to vote? All those in favor? All right, that's unanimous. There was a report discussion, whole health department and program alignment.
I feel like I'm going to burn you guys out if we talk about this, although we punted it from last month, so I don't know what you want to do.
Well, we have about 20 minutes. We can, if it's okay with you, I know you all have other things that you have to tend to. We can push it for April.
Yeah, that's fine. I mean, I can also do it maybe in 5 minutes and then field question. I don't know.
I'm gonna leave that choice up to you. I don't want to squish it to 5 minutes if it doesn't need to be. So I don't want you to feel rushed.
Okay, why don't we move it to April? That sounds good.
All right. Thank you. And Bridget, I think you said Veterans Affairs with JR?
Yes, JR, I think is here if he would like to cover his goals. Go ahead, JR.
Yes, I would. Good morning, everybody. Oh, man. Good morning, everyone. I know I'm not there in person.
Good morning.
Good morning.
All right. Good morning. Thank you. Hey, thank you. It sounds like there's kind of a theme here from everyone's, because my department's goals are also internal and external, kind of a dividing line. And also, this is kind of exciting that having a full staff now, able to have feedback from everybody in the creation of these goals. Some things are things that I've myself have seen and just really wanted to make sure that we can do, but others are, it's been real important having different perspectives in here, particularly with the addition of our veteran service officer, bringing in fresh eyes with everything. So as you'll see the first 5 goals are the ones that are more internal facing. The big one, the coordinate completion of move to new spaces. We have been in here over a year. Probably closer to a year and a half, but we still have a punch list of things that we'd like to get taken care of. You have to say thank you to facilities. I want to sound like I'm not, I don't want to sound like I'm complaining about anyone, but we know that there are different priorities that have happened with the county, so we kind of get their attention between different things that are happening. So we do have a short list of things that will really help our department to function more fully, as well as to be more attractive. We've already gotten a lot of comments from people, from veterans and their families when they've come in and saying it's really nice to see that we have our own dedicated space. And that is something that we're definitely thankful for. But there's some other things that we want to finish putting on here so we can do the idea is to do a big open house, which is number 6 on our list, but also just really doing a big welcome to the community, as well as being able to have a place where we can do several things at once. The second one is developing a standard operation procedure manual. Again, this is having fresh eyes here. There are a lot of things that I've been doing this primarily by myself for the first 5 years. So there are a lot of things that I've developed practices, but a lot of times that doesn't translate in trying to help someone else. So the idea of being able to have it all written down, having a place where someone can go and see the things are, that helps both in the education as well as any future expansion of our department. We'll be able to put things in people's hands and help the learning process. Our number 3 about exploring and implementing comprehensive veteran intake. In short, we just want to be able to come up with a way that there's a single point of entry for our veterans information, and that we have basically a comprehensive place where we can do everything in one space. Right now we have about 3 different areas within our own system where a veteran's information and keeping track of their cases and information is. And we'd like to just be able to pull that in, look at ways to pull that into one space. And with a look on being able to improve the consistency in how we service our veterans and how we identify needs, or even better to have things that crop up that maybe we see trends that we need to pay closer attention to. In developing a departmental communication strategy, basically want to look at expanding our digital footprint, taking advantage of technologies. There's a focus on having our social media presence, as well as a revamp of our website. There's some things that we'd like to be able to just add and have our website itself be a service in itself for anyone who visits our department looking for information. And then the 5th one, which is what I'm kind of most excited looking forward to, and that's collaborating with administration and HR to really look at how we how we show appreciation for our veterans who are on our county's workforce. We know there's more than just the 3 here in my department, and it'd be nice to be able to do some things that give them an extra thank you. The idea, the inspiration for this came from, there are a couple of places around town where they've asked me to come in and speak to their staffs for different events and to see how they treat their veterans who are on staff in such a celebratory way, so to speak. It's really kind of a good contagion. It's a nice inspirational thing, and I think it's something that would help build in more pride amongst our veterans community, both in their status as well as working with the county. Moving to our external things, I mentioned the open house. I really do look forward to being able to showcase that, showcase the different things that we have here. Particularly one of our newest things is we have one of our Gold Star moms, Mrs. Kathy Carpenter. She really wanted to do something in a way that gives back to our veterans community. And so we've come up with what's being called a Patriots Pantry. And basically it's a wardrobe, it's a closet that has different necessities for vets who may be in need, whether they're somebody who's come to us in referral from another agency or someone who just stopped here because they're trying to find housing, they're trying to find services, they actually need something. So we want to be able to showcase things like this and other opportunities that we have within our department. The needs assessment is something that is part of our strategic plan requirement, and that's really being able to get a good idea of what it is that our veterans community actually wants and needs. We have a good idea just because Tompkins County being who it is, a lot of people call in and they let their voice and their opinions be known. But we'd like to be able to put something down on paper so that we can actually track our progress and probably most likely even find things that we've totally missed that other people feel is important. Strengthening existing activities and support our underrepresented populations. Basically, this is something I would like to do, helping leverage our grant through the Dwyer program, Joseph P. Dwyer Peer Support Fund. This is looking at signature items, looking at strengthening things that we do that target specific veterans communities, and being able to see what are things that we can expand on, what is it we can deepen our commitments to service with them. Good examples of those are currently we have a women veterans group. We have our Vietnam, we have a key signature event that we do each year with our Vietnam veterans. And we also have one of our newer things is activities that are focused on college age veterans. And particularly with them, those are ones who have just come out of service, maybe just have been a few years out of service. And between the stress that can come with transitioning from the military world to the civilian world, and then you're adding academic pressures onto that, we like to be able to do things that can help them stay engaged, help them be socialized, and basically just have fun when they can. There's a time to either let their hair down or even expand their own network of friends. So those are the kind of things that when we talked about strengthening existing programs that we're looking forward to doing more of. And creating an outreach strategy, basically what it is, we wanted to, we feel like we do a lot as it is, but a lot of times what you think you do and what reality sometimes can be different. So we want to be able to do better about reaching out to people, letting folks know about what is available through our department. This gives us particularly opportunity to leverage the different resources that are available to our veterans community that through Tompkins County. And so things like that, looking at outreach to different parts of our county and basically being able to otherwise promote awareness. Those are the goals within number 9. And then lastly, the Achieving the Purple Heart County designation. I think you've probably seen when you've driven in other counties, there's usually a purple sign there at the county border. And so we want to be able to do that ourselves. And it's something that shows that Tompkins County as a government acknowledges and respects our Purple Heart recipients, amongst others. But those are the ones who have really, to have a Purple Heart is something significant. So we want to be able to have a visible public show of that. Trying to run through things pretty quickly because, like we said, time is of the essence, but just giving you a good overview of what that is. Also, our indicators, we also have 2 indicators. accessing to public services. We want to be able to do a better job of tracking our referrals. A lot of times people come in, they call us when they come in, and what they need is something maybe we can't do, but we can help facilitate. So we refer them to other departments within the county or to other agencies within the Tompkins County. So we want to be able to just get a better idea of what those are for folks. And then intentional inclusion kind of goes to what I spoke to earlier about being able to identify groups that are, I guess, specific groups that we know that are not as well represented. For us, it's a little more difficult because everyone we work with is considered a protected class. So in their own respects, the veterans population is a minority population, but we're also looking at within that group, there are different segments that we want to be able to make sure that we're able to reach and serve better. I'm doing a quick overview. I think that covers everything. I also do know, sort of mentioned in my updates, but on the 20th, I'm looking forward to, or I should say, our department is looking forward to hosting many of you here, as well as your other colleagues, for our orientation session with you. And so we'll be able to, if you have other questions, please feel free to bring those to that session as well.
Nice, thank you, JR. Is there any questions for JR?
Just a comment. I want to thank you for your dedication to this special population in our community, and especially in recognizing some of the severe mental health challenges that they have. And it sounds like you are just the person to really understand that and help people adjust. So just want to acknowledge and thank you for the work.
Thank you. I appreciate that. We work hard here, so all three of us really jump in on that.
All right, any other questions? Thank you, sir. We appreciate you and your goals. Well, I'll check with you offline about something else. So I'll give you a call this week.
Okay, sounds good. I do have a few things just in the way of updates.
Sure, go ahead.
Share those. All right. We've had a few things going on between this month and last month, in addition to our regular daily service to our veterans community. One of our, well, it's kind of a local highlight is that Ignacio Lopez, our veteran service officer, he just completed a week-long accreditation training with the National Association of County Veteran Service Officers. So once everything goes through with that, there'll be two of us in here with that designation as well, which basically expands more of the resources, particularly if we have questions or there's cases that are happening. It expands our resource that we can look to call upon ourselves in helping our veterans with claims when they're trying to get service-connected disability ratings. Last month, we had our first Veterans Tubing Day. This is something geared toward our college-age vets, so had a meal and a day of tubing at Greek Peak, so which was kind of fun. We did this in collaboration with our counterparts in Cortland, and it was a good day on the slopes. And ironically enough, I think that was the 50, 60 degree day. So I was afraid that we were going to lose all the snow, but what it really did was make the slopes really slippery. So some people went far in their tubes. This Friday, we will be having a pre-St. Patrick's Day celebration, doing this in collaboration with the American Legion Post 221, which is our Ithaca post on South Danby Road. Saturday the 21st, we are collaborating with a new venture called the Baby Brigade. This is something that's been spearheaded by college veterans up at Cornell, and they're having a big public baby shower where they're bringing a lot of baby needs that they want to be able to give to the community. This is something that they're viewing as their way of giving back, both to our veterans community as well as to the community at large, knowing that baby needs are a big thing in Tompkins County. And then on the 29th, which you all, I think you've already got my message once, but you're all definitely invited to our signature event, which is our Vietnam Veterans Recognition Day luncheon. And this is going to be on the 29th. Will take place at the GIAC Recreation Center, the new GRC. And this is our time where we do a big public welcome home to our veterans who served during the years of the Vietnam War. And all of these are in addition to our normal our normal activities that we have that we sponsor each month. But one thing that's going to be pretty cool is that, or two things. We are extending our celebration of Women's History Month into April and having a special night for our Women Veterans Group on Friday the 3rd. So we want to make sure our women veterans, and they are able to bring their families as well. So this is going to be a family event for them. And then later in April, we're going to have our second year of collaboration with the Cornell Veterans Law Practicum. We're having a veterans drop-in law clinic so that veterans who have legal questions, legal issues, they will be able to come in and have a 30-minute session with a law student or a law student under the supervision of their professor, who's also a practicing attorney. So.
All right. Thank you, sir.
Yes.
Appreciate your work.
We've got a few things going on, so appreciate the opportunity to share.
Absolutely. Kate, do you want to share?
So just to update you guys, I did want to just take a second. Patty Van de Bogart's dad, she is the chair of our youth services board. Her dad passed away, Monty May, and his services are today. So I just wanted to acknowledge that. We are in the process of preparing for the departure of my deputy director, who will have 37 years when she retires in July. And so we are assessing, really looking at the department and goals, and really making, to Jenny's point, making sure that we're setting goals that are attainable and realistic for what our capacity is going to be over the next couple of years. And so that's ongoing, talking with county administration to make sure we're getting that right. And we are also speaking with the facilitator that is helping Office of Family and Children Services roll out the new wellness domain. She's putting together a scope of work for us. We're going to hopefully be able to bring her here in the next couple of months and roll out the new wellness domains, which is really going to help centralize our focus. And you'll hear more about my equity indicators next time, but just looking to make sure that the data is informing the decisions, and our funding is, we're going to be sending that out in April for another 3-year cycle. So
37 years, those are some big shoes.
Yeah, trust me. Yeah, I know. I had tried to talk her into staying just a little bit longer, but no go. We'll miss her.
37 years. Any questions for Kate? All right. Lisa Monroe in COFA, do you have any updates you would like to share? There we go.
I'm having problems. I'm sorry about that. I don't really have any updates. We're still preparing for our move. Thank you, Kate, for mentioning Monty. Monty was a big presence in the community and was very engaged with helping older adults with he kind of started the wonderful wheelchairs program that exists and did a lot. And his wife was on our advisory board for many years. So thanks for mentioning that. But other than that, I do not, again, getting ready for the move.
Monty, I think I served with Monty on the Community Whole Health Commission years ago. Yeah.
I bet you did. He was a big presence with a booming voice. He was a good dude. Yeah.
Wow.
But that's all I have. Thank you.
Any questions for Lisa? All right. Cindy from HSC.
Hello. For the purposes of time, I don't have any major updates. I can't wait till next month. But if you have any questions, happy to answer them.
Do you have any questions? All right. I guess you are off the hook, and we'll go to Liddy. Is she still here?
No, Liddy had to jump off for another meeting. So she also told me she didn't have any major updates. You know, we're all very busy right now with situations. So I'm sure we'll have more for next month.
All right. That sounds good. Is there any committee member reports? All right. We are adjourned. Thank you.